Welcome to the Eastern Mediterranean Climate and Health Responders course, Session 6 on floods, waterborne diseases, and other health impacts. I'm Caitlin McGraw, and I'll be moderating the session today. We also have simultaneous interpretation, which is available in Arabic. You can press the globe button to select that interpretation channel and listen in Arabic there. If you would like closed captions, please press the CC button on the bottom of the Zoom window. We also include French captioning as well. The course objectives are to enhance the knowledge, confidence, and communication skills of both current and future health professionals concerning climate change impacts on health so they can deliver improved public health and clinical care by recognizing and addressing climate risks, serve as trusted advocates, influencing policy and practice within their institutions, communities, and professional networks. Number 2, equip current health professionals with the knowledge and skills to educate their institution's own learners, ensuring that climate-related health impacts and emergency preparedness are systematically integrated into pre- and post-licensure training worldwide. And 3, build and strengthen an agile and informed community around climate and health education, advocacy, and policy for health professionals with strong mentorship and expert support. Here you see we have our course schedule of 11 sessions, which occurs every Wednesday. We're on March 25th, session 6, floods, waterborne diseases, and other health impacts. And the session learning objectives today are to identify short and long-term health risks from extreme weather events, water scarcity, and water contamination, and outline health professionals' roles to reduce these risks. Number 2, to understand how biological, social, economic, and structural factors can heighten vulnerability to extreme weather hazards and waterborne diseases in the Eastern Mediterranean. 3, to identify the role of disaster risk reduction, early warning systems, public health communication, and regional cooperation in preventing health impacts and minimizing forced migration. Number 4, to apply knowledge of climate impacts to waterborne pathogens, to improve disease prevention and response strategies. And number 5, to assess how floods and other extreme weather events disrupt healthcare facilities and essential healthcare service delivery, and identify adaptation and resilience strategies to maintain continuity of care. Unfortunately, due to to the circumstances in their region, one of our speakers will not be joining us, so our session may be somewhat shorter. I expect 30 to 45 minutes, and we will only be including the case study later in the week. Our additional speaker will send a recording, which we will share with you over email. Due to the current situation in the region, this course will operate with flexibility, allowing both synchronous and asynchronous participation. You can attend the sessions live on Zoom, watch the recordings on YouTube, and if you do not have access to either of those platforms, recordings will also be made available via Google Drive. To count attendance, we will ask that you sign a statement confirming that you have watched at least 7 out of the 10 sessions. To receive your certificate of participation, participants who attend or watch 7 or more of the sessions and pass the final exam with a score of 70% or higher at the end of the course will be awarded a certificate of participation in climate and health from the GCCHE. This certificate is only available to people who use the same email for registration, all Zoom sessions, and exam. For the final exam, the exam must be completed using the same email address and will be sent on the final day of class via email and will close on May 4th, 2026 at 11:59 p.m. Cairo time. There will be 25 multiple choice and true false questions, and participants should be prepared to take the exam in one sitting. If you would like to join our WhatsApp group for updates and information from the course planning team, please see the link in the chat, or you can use this QR code here. Wait just 1 second if anyone would like to do that. And today, unfortunately, Ms. Naima Al-Gassir will not be joining us, but we'll be sending a recording in later this week, which we will notify you via email. And today we will have Osama Ali Maher, who I will introduce in just a moment. I'm gonna stop sharing my screen. Okay. And would you like to go ahead and start sharing your screen, Osama, please?
Yes.
And then I will introduce you.
Hi. How are you? And really happy, and I feel lots of responsibility since I'm now the only presenter in this session. Really thrilled to see so many people. I was just following the countries appearing on the screen, and it's really a pleasure, and it's a joy for me to be delivering this lecture to this cohort of people representing almost all the corners of the globe. So since there nobody had the lecture on the on the um, on the floods and the consequences of floods, you can see my screen now. So I will just put it and just have some thoughts about the climate and extreme weather events. Let's say the droughts, and you kindly pointed out that also droughts can have a kind of lethal impact on the population. I came from EMRO, from the Eastern Mediterranean Regional Office for the WHO, and it's a very diverse region. We have 22 countries, and these countries are most of the time exposed to floods and droughts, extended droughts, like in the Horn of Africa. And in some cases, and some of our member states are experiencing droughts in one part of the country and also floods in the other part. Typical of that is Pakistan and Afghanistan, for instance. So, and we have a very high income countries in our region, and we have low and middle income countries as well. We have 11 countries in either in direct conflict or active conflict, and also chronic or transition type of emergency. And unfortunately, the current Gulf in the war is an example to that, where after 20 years of working in emergency, I would confidently say that this is a very different emergency, where environmental issues and environmental hazards are the one who's leading all the events there, away from the direct conflict, of course, and bombardment and missile attack, etc. So there are lots of questions about air pollution, etc. What I want to say is that, and that's also relevant to a good introductory to this with the floods, is that no two emergencies are identical. No two floods are more or less identical. Not even in my region, Pakistan had witnessed a major flood in 2010, was more than 20 million affected population. And then in 2022, there was another flood that was massive, and the response was different. Every year we are getting floods in Sudan, and two times per year in the rainy season. And it seems like we don't learn a lot. That's the lessons learned. We experience the same event, the same extreme event, and we see the health impact almost identical, but it keeps on happening. And if I'm talking from my region's perspective, that the problem for me with flooding and climate change specifically is that we don't have evidence. We don't have enough research about what's going on in my region. The case study that I will be presenting now is about the cholera. The the largest cholera outbreak in modern history recorded, and how we dealt with it, and what actually we are missing, and what we are calling on academia to help us with. The cohort in front of me are all decision makers or health practitioners, and I think it's time to bridge this gap. I have my background is in academia, but I'm a practitioner. I worked even on subnational level. And there is a disconnect somehow. And I thank my colleagues here at Columbia for this trial, because the gap between the practitioners who doesn't have a time to produce evidence or to record lessons learned, and also academic, where we need grounded data. We need to see real situation. This gap needs to be bridged in a way. When talking about floods and the case study from my region, there are two hypotheses. One of them is that after all, every flood, there will be increase in diarrheal cases, increase in vector-borne diseases, and there is another hypothesis that the bacteria will be washed away, the Vibrio, due to the flood, and then you should have a decrease in diarrheal disease. I saw some of literature on both sides, and obviously the biggest portion is towards the first assumption that, and there are evidence for it. And even due to the mixing between sewage water and flood water, population displacement. So for the first think about that, it's complicated. That's why we need academia. That's where we need the brain who's out having some time to think and guide the people in the field and guide even policymakers. So what I will be presenting now is the floods and its impact on the cholera outbreak in Yemen. And just to showcase,
Dr. Ali
please,
Maher. May I
yes,
please introduce you really quickly before you start? I'm so
yeah,
sorry.
please. Oh, okay.
Thank you so much for your
Oh, thank
really
you. Thank
well
you.
thought.
Sorry for that.
No, it's okay. Thank you so much. I just want to take this moment to introduce Dr. Ali Maher, who is acting regional advisor for climate change, health, and environment at the WHO Eastern Mediterranean Regional Office in Cairo, where he leads technical work across 5 domains: climate and health, WASH, occupational health, food and safety, and chemical safety, covering 22 member states. He is also an associate research professor at the United Nations University Institute for Water, Environment, and Health, and an affiliated researcher at Lund University in Sweden. With over 30 years of experience spanning public health, environmental governance, and policy, Dr. Maher has led health vulnerability and adaptation assessments across the Eastern Mediterranean region and developed the analytical framework Climate Loads the Gun, Governance Pulls the Trigger, which demonstrates that governance factors explain significantly more variance in climate-sensitive disease burden than climatic variables alone. We welcome you and your expertise, Dr. Maher. Thank you so much. Thank you so much.
Thank you very much, Caitlin. That looks like I finished my makes me feel like I finished my presentation after all the talk I had. So no, but that what you said by the end is actually the whole concept that I'm trying to introduce, at least in my region, which is the climate is loading the gun, but actually other factors are pulling the trigger. So I started to do it differently now by starting by the conclusion. So you guys feel free to think that you finished the presentation. And this is actually the conclusion of my presentation. The Not all the time the climate is the bad guy. We tend to have this in mind, that everything happens, it's the climate. In the EMR, we are having witnessing an increase in malaria cases since 2008, and we are just having this emotional thing about that the climate is the bad guy in this game. But after research, we discovered that it's actually not the climate, but governance. I mean, the climate is the one who's loading the gun, but who's actually pulling the trigger? Lots of factors are doing that, but most of it is the governance, as we will see. Water, sanitation, and hygiene, or WASH, is one of the problems. But really, whenever we are dragged into a discussion on climate, don't be driven by emotions as a policymaker and a responder. Just try to have one step back and try to see, is really climate is the bad guy, or there is other other factors. So the thing in 2017, or actually it started 2016. The conflict in Yemen started 2015, if I remember the dates right. But the first wave of cholera, and cholera is endemic in Yemen, it was okay.
Yep.
Nobody really paid attention to it. But then came 2017, was two peaks during 2017, and they were associated with the rainy season in Yemen, which has two peaks, I mean, in spring and in autumn. And the problem, Yemen landscape, the political landscape is very complicated. We are almost dealing with two separate health systems, two separate surveillance systems, and we are we were struggling on this, not just fighting an outbreak, the traditional role of humanitarian worker, epidemiologists, public health servants, etc. But the problem for me was that we reached around 2.5 million suspected cases during these 2 years, which is the highest recorded in modern history. There are lots of literature talks about inflation of the numbers, and that we will be talking about later. But the official ones, that we have almost 4,000 people died of cholera, a very simple disease to treat, but it shouldn't cause any kind of fatality, but that's what happened actually. Almost 4,000 people lost their lives. So there is an active some elements that made Yemen very complicated, very difficult to study, and very difficult to understand. But at the same time, it was interesting from an emergency management and epidemiological point of view. So we have a wash system that's collapsed. We have a health system that's overwhelmed by the outbreak, but it was not even functioning before. And we have the seasonal flood, which is the moment that we are here to try to figure out how this dynamic worked with the flooding. So that's a timeline of how this outbreak started in October 2016. We started to report some cases. Nobody paid attention to it. We came to 2017 in April. Rains returned, and then there is an explosive surge of cholera cases, suspected cholera cases, and then we can have a debate about what we mean with suspected cases. These 2.9 million of almost 21 million or 24 million, the population of Yemen. And then we had a second wave, and then we have some international response in July 2017. We started to have the rain in 2017, but in April, but then came the response in July 2017. And then we have the weekly peak of almost 40,000 cases reported per week. And then we have another resurgence in 2019. So that's okay. When trying to study how the cholera is dynamics is going, and fade away from this simplified form of we have a rain, then we will have a cholera outbreak or elevated number of diarrheal diseases, we actually could have some governorate level data about the reported cases and some information about WASH facilities, and we could from a distance do some analysis to the precipitation pattern, because in this context, it's like a data desert. It's very difficult to try to find reliable data. But we took the period between May and December 2017, and that part of the AP curve, we had it like a gold mine to try to use AI, artificial intelligence, and machine learning models to try to have a model that we think is logic, and then to start to train the model during these periods and then validated and then to test if this model can work and predict to us the whole cycle of the AP curve. So why this is a golden this is the full AP curve with the two peaks in 2019 and 2017. So this this part where we had lots of data on governorate level and subnational level eh, can make us or enable us from making all kind of validation and learning and really investigate all the parameters we used to include in the model and to see the result how this will act. So we have a seasonal flooding and you have a wash collapse, we have fecal. That's the causal chain of diarrheal diseases or cholera. And then we have the health system, and that includes also the external humanitarian assistance. And then you have an explosive transmission. And I think many of the colleagues online will put on the table the issue of the inflation of the reported cases, the contribution of the aid agencies in this kind of setup, etc. But what I want to have as a disclaimer, these are the published data that we could collect, and these are the data that we are measuring the success of our model on. So the most and my sorry, my colleagues, the epidemiologists. I'm an engineer in the background for trying, but for me epidemiology is more or less an engineering thing. The SEER model is the most common thing, and it's a mechanical pure epidemiological one, depending on the mechanism of transmission of any kind of disease during an outbreak, communicable disease during an outbreak. So the CER is very understandable, and it works in many circumstances. But when you are talking about a bacteria or a virus that needs the environment, of course, to transmit or whatever, then we decided to have a fifth compartment here for the environment and water and sanitation. So we had the classical one, and that's for the cholera. The susceptible, we said, assume that 28 million, total 16 million without safe water. This for me is the cohort of the susceptible population. And then the exposure, 1 to 3 day incubation period. And then there have the symptomatic cases will start to 5 to 7, and then the recovered one, either they will get outside of the scope of the model or they will return back as an infect, and then we'll try to have an environmental component. What I want to say that is SEER will give you a good result, but we try to have the environmental aspect of it. So during this period that we studied, I mean, there was like 800, almost 900,000 cases, and that's a big portion of the total outbreak. The attack rate is like 3.16. The weekly peak is 35,000, and the case fatality is 0.25. The threshold for the case fatality rate for emergencies is 0.1%. So the training of the performance of the model that we started with, and that's the beginning. It was the random forest model, and random forest is just like scenario building to whatever actual data you are correcting, and then it builds lots of scenarios at the same time and see the most accurate one. And it actually produced something good to see the increase in cases. But then the forest model is random forest model failed catastrophically after to predict the peak and also the decline, because it gave me like a real flat thing, which made me, okay, the random forest or the classical mechanic models, let's say, are failing to have this kind of dynamic thing. So we had the growth phase, the phase transition, and then the decline phase. And the testing period from December to 2017, that was the catastrophe when we said that the random forest will not work. This is one of them. Forget about all the scientific background. I will leave it in the back. But when we try to have the model to work, meaning that we had the climate indicator, precipitation, temperature, humidity, or whatever. We said in this fifth compartment of the model, we said we will try to be as comprehensive as possible, meaning like we will have the conflict as an indicator. So, so the conflict as an indicator, we can have it in a number of attacks or fatalities caused by war or whatever. So you can make a quantification to the conflict. You can include, if you want to have a good prediction, you can have the displacement, for instance. You can have malnutrition. You can have the suitability of the temperature suitability for the Vibrio, and so on. So we had like around 32 indicators to try to see which of these indicators is the most significant for the cholera outbreak in Yemen in 2017 to 2019. And we saw that humidity is the biggest one. A random forest feature due to the random forest and nonlinear relationship. But the composite vulnerability is the governance, is the fourth attribute, and then precipitation and the humidity. So the climate in this kind of context, it can predict when the outbreak would start. As we said, after the flood incidents, we can expect like there will be an explosion of diarrheal cases, or in a country with endemic cholera, it will be a cholera outbreak. Identify the seasonal window, because we said that the seasonal variation, we have two seasons for precipitation in Yemen, for instance. Rainfall, extensive rainfall can trigger the first peak, for instance, or resurgence in 2017. But it cannot explain the outbreak magnitude. It cannot tell me that how big the cholera outbreak will be, because that's left to the dynamics on the ground. And as all the indicators, the 32 indicators that we included in our analysis and modeling, and it cannot predict when this cholera outbreak or diarrheal disease outbreak will decline. One of the most important things that we didn't include in our model or couldn't do it is, for instance, the increase in immunity due to vaccination campaign, the oral cholera vaccine introduced to increase in immunity, self-immunity of the population. So there are so many factors that can contribute to that. The models, the normal models, will not be able to predict a decline in the AP curve. And it's insufficient for resource planning, because I assume like a linear increase in anything, and that's not good. The governance variable explains like 4 to 6 more than the magnitude of the climate indicators. WASH functionality determined scale. The WASH facility, especially in cholera outbreak, the health system capacity, and in this study, when the health system was occupied by 50%, non-functional over 50%, all other indicators had no impact at all on the spread of cholera during this cholera outbreak. So what I mean is that if you include, the more indicators you include, the more that you will discover that climate is not actually the bad guy in this thing. We just take it emotionally, but in reality, you need to understand the situation on the ground. In the same thing goes for malaria, for instance. The malaria in EMRO is increasing since 2008, and when we did a study that we published, we discovered that it's the same hotspots recording more cases of malaria, rather than blaming the climate on the increase in suitability for the vectors, because our region is already suitable for the vector anyhow, for the Anopheles and other vectors. Leishmaniasis, for instance, had been linearly increasing during the conflict in Syria, but not related to climate. It's other factors. So, well, I'm not defending the climate. I'm not trying to change the global. I'm very strong advocate for combating the climate change and etc. But we need to be a little bit realistic and scientifically based when we are talking about the increase of disease incidence due to climate. So the governance itself in Yemen, we have two different systems, as I said, and one of the reasons that if you want to try to study the case of Yemen, is that in the beginning there were no report because of the stigma of the cholera at all. And you will find the surveillance system capturing almost no cases. And then when the humanitarian actors came in and there was lots of money dedicated to the cholera, all symptomatic, a differential diagnosed diarrheal episode will be reported as a cholera. That's why you got the 2.5 million, but this is another discussion. But what I mean is the governance, politics, and what I could say political epidemiology, if I would say so, plays an important role in these things. So when I had the SEER, and if you look here, you will find the PME is around 25 more. What that means that our modification for this for the SEER model is here is the traditional one without adding the fifth component is like seven time higher than the actual value, uh, which is really telling us that we cannot just have the SEER model or the mechanistic kind of models. Okay, the last thing that we did, okay, we could perform the model could perform well until 2018. It kind of give good results, but then in 2019 it failed actually, and it has a peak here. And that's not a weakness in the model itself. It's just a signal to us to maybe we missed something like the increase in immunity of the population, restoration of health system through external aid or whatever. But that means that we are on the first on the right path, I think. Having the mechanistic model, then modify it and having environmental thing, including the climate change, we can predict this. Why this is important for decision making? Because not all the time you have data, and that's the problem. If we try to have like a kind of a modeling, whatever kind of modeling amid this mega outbreak of cholera, maybe we have succeeded a little bit. Now we have some time to work our heads together to try to, and also with all the new possibilities with machine learning and AI models, etc. We can really try to put our heads together, be pragmatic. Maybe not everything is caused by climate. There are other factors that are important or as important as, or in some cases are more important. So that's is a waterborne disease. Is it preventable? Uh, if the if we didn't do our homework, then there is a possibility that the situation will get outside of our hands. So this is just a scheme about the critical window that we need to act. And before even acting, we need to do our homework and have all these elements in place in order to respond. So these are the three lessons for every professional in the room, that surveillance must be conflict resilient. And I don't mean that physical surveillance that should actually exist on the ground or the one that we are relying on, but if you can have tools for satellite imagery, I cannot do a full analysis or I cannot have data from all places in Sudan with the conflict ongoing, with the ongoing conflict now. I need to open my mind and start to depend for this type of circumstances to use satellite imagery, remote sensing, open source data in order to get as much information as I get, and then I can substitute those models to get the full picture. So the image that every time I have a flood that I will have increase in diarrhea, maybe in many contexts, yes, it is, but the thing is that it can be reduced dramatically if we understood the situation and if we could react in the proper time. Governance, and as I told you, if you want to control malaria, for instance, and you're due to conflict, your malaria control program is on halt because of a conflict in accessible areas. You cannot just blame the climate for the whole picture. You need to understand how things are. In Yemen, it was very complicated, as I said, because you are dealing with two governments, more or less, two health systems that you need to have the compiled picture in. So Yemen is not historical actually, and as I said in the beginning, um, we don't learn too much. The current crisis in the Gulf, for instance, yeah, it sounds from a distance that okay, the GCC countries especially are high income countries and they can sort out their problems, but there were something that we are preparing now about the desalination plants because they are getting all the water from the Gulf, as everybody knows, and the Gulf now is polluted due to the ongoing war, etc. So there is a possibility that these desalination plants, which is the not the backbone, it's like everything for drinking water is cut. And sometimes there is no accessibility to many countries if they have the money. So now we will have a shortage of water. So and God knows, or this all the scenarios are there. So the infrastructure disruption, even in a high income country, will lead to water insecurity. Water insecurity. We don't have enough water. That will be a window for waterborne disease risk. And if there is no governance, you will have no response, etc. And if the health system is under stress or during a war, so all scenarios, even the outbreak of cholera in Yemen might not be replicated with the same magnitude, etc., but the overall frame can be migrated to other countries. And that's it's not a question of sea level rise. It's not a question of increase in changing the pattern of precipitation or increase in temperature. It's much more than that. And I think the fight with climate is a long fight, but the fight with the consequences of the climate on health, for instance, and on for extreme weathers can be really getting far better if we really could understood the problem and have a good contingency and we prepare, but we need to have a scientific basis for all of this. So I'll stop here and thank you for listening. I think I extended my lecture, Donnelly. Thank you very much.
Thank you, Dr. Maher. That was a great talk and very insightful. Um, we have and so relevant right now with different systems at play and conflicts. We have several questions that I want to ask the speaker, and you can answer them live since we have a little bit of extra time. The first one I would start with is how does flooding specifically alter the transmission dynamics of waterborne diseases like cholera?
I think I touched a little bit upon that, meaning how it's altering. If you have a normal situation with an infected person who's having the Vibrio, and it's a fecal oral thing. So if you have the Vibrio cholera, the bacteria itself in your hand or whatever, and then you get in touch with another person, that would be the direct transmission. If it's in the water sources, that will be the same thing. If someone is the feces is in the water and then someone else is using it without the proper hygiene, he will get it. But how the question is how the flood altering all of this? Yes, you will get a flooding of the sewer system, for instance. Then, if the bacteria or the Vibrio is not was contained in the wastewater, and the risk of getting it is low. By having a flood, that will flood the wastewater system, and then you will have a bacteria up on the land and exposing more people than the normal circumstances. So the short answer would be whenever you have a flood, excessive water, this water may, if contaminated, it makes the exposed population bigger. And if it entered the wastewater system, that will make even the concentration of the bacteria more. So you are having a double-folded thing. You can imagine increase the both the exposed population and the population of the bacteria itself. I hope that this was the answer to the question.
Great, thank you. The next question is, which step in the causal chain represents the most critical intervention point and why? And they're referencing flooding, wash collapse, transmission, overwhelmed system. Which would be the most critical intervention point and why?
Yeah, that's a very old one of the first graphs that I think it was London School who published it, and it's very famous. I mean, they had like the first thing is the clinical care, of course. I mean, for cholera, it's like it's a simple disease, and like you will have an IV fluid, etc. And then you will have the drinking water. I mean, let's say the clinical care will reduce the morbidity by 10%, and then you have improved in drinking water that will add like 20% to it. But the most critical thing is enhanced sanitation. And thank you for this question, because that was a dilemma during the cholera outbreak in Yemen, because we all know that sanitation is the source. Sanitation is the problem. Sanitation, where you will find most of the source of contamination. But as humanitarians and humanitarian assistants, will go for drinking water. So working on drinking water is the most effective one that we used to have. While, and that I will just have it by the side, sanitation is the problem. If you want to invest, if you want to break the transmission cycle, you need to work on the sanitation system. But unfortunately, sanitation systems investment are very huge, massive amount of money to restore the sanitation system of Sana'a, for instance, which you will not find that donor is interested in. So back to the question, to concentrate it. The most effective one would be the sanitation, but we don't have that huge resources. So what we are doing is ad hoc. By the most effective, second most effective thing is the drinking water. And the drinking water, meaning that we need to treat the water at the household level or the consumption level. And that is with what we used in the humanitarian space by using chlorine tablets, etc., to clean the water. And that's how we are, and also community mobilization, hygiene messages, etc. But drinking water is the most important target, but the ground cause is the sanitation. I hope that I answered the question.
So this household level water treatment, drinking water treatment might be a great intervention
Oh, it's a
point,
must.
especially in times of,
It's a must. You have to do
conflict
it.
or
You have to do it. That's the
infrastructure
only thing we
failures.
have. Yes, yes. I cannot invest in a mega project. So what I do is just forget everything. And that's what I say. Even not water quality monitoring in the full spectrum, just concentrate on free residual chlorine and make sure that the people are drinking chlorinated water. That's it, a blank chlorination.
Thank you. Um, okay. One person asks, why is the 48 to 72 hour window after flooding critical for preventing outbreaks? What specific actions should be prioritized within this window?
The 48 hours is the minimum that you will start to get symptoms. And that's why it's the alarm for us that we started to see lots of cases started to visit the primary healthcare unit with diarrheal diseases, etc. So the 48 hours is the first warning. That's why we need to be on alert for it. And that's the 48 hours is not to be looked at as the 48 hours because you need to look at the rainy season before and to monitor the meteorological indicators like rain and see if you have a massive rain. 48 hours is when you will start to receive the first cases of diarrhea at your primary health care. And in that, at this, you should have your contingency plan with ORS, with chlorine tablets, with whatever. I mean, the system is not perfect, but you know exactly what to do after these 48 hours. Maybe the immunity in the community is high and you don't see anybody after the 48 hours. Then the immunity is high, they can take care of it, etc. So we need to understand that we are working in a very, very resource limited environment. I'm talking just about Yemen. I hope that I answered the question. Thank you.
Yeah, it seems like that surveillance might be a critical point to know when those outbreaks are starting. Okay, the next question is, during the time of the cholera breakout in Yemen, how did frontline workers differentiate between cholera and other flood-borne diseases like dengue or malaria when patients would have presented with similar symptoms? And was that taken into account in the statistics of the model?
A very brilliant question, actually. And of course, these are two categories. I mean, the vector-borne is different as a differential diagnosis. I mean, you can have it with any other severe diarrhea, or you can mix the diarrheal cases, and that's actually what happened. I mean, people started to mix the. I never saw in my life a disease that got nicknames as the cholera. Uh, Really, it's acute diarrhea, severe diarrhea, acute watery diarrhea, etc. And all of these, AWD, acute watery diarrhea, is the most famous in our region. And actually, it's a symptom, not the disease itself. So, back to the question, yes, it happened that people were unintentional politically because you need to have a case definition. 4 or 5 incidents of water stool, rice stool, etc. There is a WHO definition, and sometimes there is a national adopted definition. And when there is an outbreak, sometimes within this context, there will not be an agreement on which definition I would use to call it cholera or acute watery diarrhea. And that's where the question is stemming. Some doctors might just report it as cholera, or at this time it was AWD. No one can force a country to declare that they have cholera, unfortunately. So the confusion between the doctors, if you don't have a specific case definition, that's one. And the most lethal one that came afterwards is that we are having over-reporting because we are getting resources to treat cholera. So there was a competition about if I report 1,000, I will get aid for treating 1,000. But if I get 1 million, I will get more money to do that. So it became a political term and a political thing. And that's unfortunately usual. So the direct thing, yes, there are misdiagnoses, there are intentional misreporting or over-reporting or even under-reporting in the beginning of the outbreak, not to have this stigma of the cholera. I hope that I answered the question.
Thank you. I'm going to move on to a couple questions about the model, the actual model. The first one is the is the AI model used for modeling the outbreak a public or a governmental one or not?
No, these are public ones. I mean, the SEER, the base one, is a public mechanistic model. I mean, it's all open source data. No, not for the training period where we had subnational level. That means you need to have ground data, and then you go to the modeling. Modeling itself is, as an engineer, I'm saying the model depends on what you put in it. I mean, the model can say whatever you want to say. I mean, let's be frank. But the models are all open source. They are all over the literature, available literature, but there must be a brain behind it. I mean, you have to do the human thinking. The other part about the programming, the coding, etc. We live now in paradise. You can just dedicate or delegate this to the AI or machine learning or any other interface, and he will do the job for you. So modeling is not a problem now. And thank you for raising this question because this is, in my opinion, this is the future, or this is the thing that will be relying lots on, especially in conflict. We have abundance of open source data through NASA, Copernicus, and lots of open source data that will give you validated one. And we came down in the resolution to a couple of hundreds of meter, and sometime it's like 100 meter analysis of climatological indicator. Thank you. I hope that I answered the question.
Um, and then there's one other question about the model. Someone asked, does the model account for Yemen's high malnutrition rates, as it could also cause an individual to become infected with cholera rather than just being susceptible?
That's music to my ear, this question, because we need to think that this was 2017. I revisited, we had at this time, we had something when we collected the data on subnational level called the vulnerability metrics. And we had like, I think 52 indicators to measure. And that was really, it was very bad. Very bad to try to convince everybody to collect 52 indicators. I mean, asking the nutrition cluster from UNICEF to collect data on stunning, for instance, asking the UNDSS to give us data about conflict, asking FAO to give us indicator about, or the WFP about security. So back to the question, the model is as accurate as you include the relevant indicators in it. And that's why you have to test the model and validate it, calibrate it, validate it, etc. So having nutrition, that's a brilliant question. It's a very determining factor for children under 5, and having if they are having a SAM or a GAM, and then they will be more vulnerable, and that will enhance a lot the model. So yes, there is an endless list of models, but you need to think about the practicality. What kind of information I can get to feed into my model and to get a good result. But definitely, yes, we need to have a nutrition rate if possible. And we can modify adding a fifth, sorry, a sixth compartment for nutrition, etc. So your point is very valid, and that's what's all about it. The more data you put in, the more validated the model, and the results will be realistic.
So next I want to ask a couple of questions about the governance factors in this outbreak. One question was what governance factors most strongly influence the magnitude of the Yemen outbreak, would you say?
Okay. When it comes to the governance, the amount of, or the percentage of the health system owned by the government or the public sector who's functioning and not functioning, for instance, because the out-of-pocket expenses in Yemen is very high. So the population is depending on private sector, for instance. The public sector and the amount of contribution of the public sector to the health of the public health of the population is limited. The healthcare regulations and situation, and depending on the agreements between the two parties, healthcare facilities is a target, or was a target, for a couple of attacks, for instance, and that weakens the public health system. The laws that regulates the operation of the hospitals in its different levels, tertiary and even primary healthcare. The treatment protocols, for instance, the laws that one interesting thing we found is the doctors and the medical staff was brain drained from the public facilities to the international aid agencies operating because of the salaries, etc. So these kind of political, let's say, and laws organizing the work of the healthcare facilities and the health system were very much significant to how to run that. And also, there are other governance thing about the pharmaceuticals, for instance, clearances. We try to have medicine inside IV fluid or whatever. There are lots of restrictions on chlorine, for instance, because it can be considered or used as a bomb or a chemical war. The custom regulations, for instance, if I'm having a vaccine, the oral cholera vaccine, and if it's not understood by the authorities, that will make it not reaching the people itself. So uh, there are other factors than just the clinical management and even the environmental one that are very much significant to it. Collapse of vaccination, back to the nutrition remark, collapse of the immunization program, for instance, in general for the children is one contributor. So these are the six, lots of indicators related to governance that had influenced the outbreak massively, more than just the spread of the bacteria.
Okay, I'm gonna do two more questions and then we'll close out the session since I know you're taking on a lot of the session today. The first one is someone asked, when is a good time to use the SEER model, the SEIR model? What types of factors would affect its results?
Um, I think, to be honest, the having transferring the model to another context needs some work. I wouldn't say or dare to say that the SEER model with all these components, it might be suitable for a conflict country to start with. But I would say that the trial that, and to be honest and scientifically honest about that, the idea will all the time be the same and valid to other contexts. Like you cannot use just a mechanistic kind of transmission to predict an outbreak. You need to add the random forest is not useful for that. You need to add multiple compartments. In Yemen, the WASH compartment, the environmental one, the governance one, was embedded in the indicators and it worked. But if you want to have it to another country, then you need to revisit first, it's a human thing, the logic. What do you feel like the most significant one will be using? So you modify your compartments, the seer first, and then the other compartments through your observation, records of outbreaks, etc. And then you see this works for a country having two peaks or two flood events a year, and the health system is not working. So these are the headlines. If you have a country like that, regardless of the area, that would be great. The second thing, before implementing this model, you could just try to collect as much data to validate it. What helped us to get kind of okay MPI was 25, I think. MAPI, lots of abbreviations. Is that we had ground data. So the final response would be it can be applicable, the core principle. You need to think about the other compartments, like the fifth and fourth after the SEIR. If similar conditions, that's an advantage. Try to have as much ground data as possible, and also try to review what models can have been chosen to your country. And the sixth one would be this can be used as a contingency, meaning that before the crisis happens or before the flood season, a couple of runs to the model would be very useful.
Great. Okay, and then for our final question, there were several questions about community action, and how that might have an impact. So one specific one was, do you think enabling the community through advocacy and active participation with oral hydration therapy or provision of chloride tablets might have some type of impact?
Yeah, that's really good because it was one of my professors who really changed my mind about this because when I started my career and everybody hears that it's very difficult to change the behavior of people in a very short time. I mean, during the outbreak. And then there are tools. I mean, there are fashions in the UN. Every couple of years appears something. It's called now RCCE, Risk Communication and Community Engagement. And before it was the 4CD by UNICEF. So, and before that, there was another one with the WHO. And he said to me that this is not true. The true thing is that when you try to convince the community by changing, you can actually changing their behavior, but not by not targeting the whole process. You just target a single moment where it is very effective in cutting the transmission. Like if you go to a mother in a village and she is changing the diapers or whatever, you identify when exactly her hands coming in the feces of the child or vice versa, and you try just to stress to her that this is what making your not her life. Don't ask her to change her life. Uh, just try to have her. Um, this is the point where your child is getting sick and you are risking him to die. And this single moment is very easy to convince the people to change their behavior during an outbreak. So get out of this that I need the people to start to use soap every day to change to cleaning their hands. Forget about that. Study where the transmission is going from a child to a mother, from a mother to her husband, to whatever, and study the relations. That's why community engagement and risk communication is the one of the most crucial things, adding it to the top of the list of interventions that we need to have to cut the transmission.
Great. Thank you so much, Dr. Maher. It was a wonderful presentation, and thank you for taking on more time and more questions today. We really appreciate you being here. And thank you to all the participants that joined and all your wonderful questions. And we will send out Dr. Olga Sear's presentation later this week via email once she sends us a recording. Um, Thank you, and we will see you next week on Wednesday.
Thank you very much, Caitlin, and thank you for all the comments that I get. Thank you, guys. Bye. Have a great day. Bye.
Bye. Thank you.
Bye.